Okay, well, I think we were due to have a 6 o'clock start, but it's difficult for people to get here, I know. So thank you very much for making the effort to come. I think we'll get underway now, so we'll run things about 15 minutes late on the timing you've got on your handouts. Thank you very much for coming. My name is Dr. Simon Blees. I'm a consultant radiologist and I specialise in musculoskeletal radiology. And it's a great privilege to have been asked to chair this meeting this evening because we are working our way through some new applications that are coming from a new piece of technology. Now, this isn't really tonight to talk so much about the technology because it speaks for itself when you see the images. So there isn't going to be a lot of technical stuff, but it's how we're using this new tool and trying to put it into current clinical problems and areas where we need increased insights. And the Toshiba Aquilion one I'll mention a little bit in the discussion, but there's only a handful of these machines in the country. And they were originally developed to do very fast volumetric CT for cardiac studies and brain studies, brain perfusion studies and the like. But there's very few people trying to push forwards into the musculoskeletal applications. So hopefully the aim of this evening is to introduce the concept of volumetric CT scanning in the musculoskeletal system, and we've assembled a panel of 4 speakers to look at different clinical areas. So this will have very much of a clinical bent. It falls to me to, if you like, kick things off, and I really wanted to introduce this concept for you of what I term functional imaging in musculoskeletal medicine. And look at the new frontiers that we're opening up as a consequence of the access of this scanner. So really I'd like to start by just saying what do I mean by functional as a radiologist when I'm trying to provide an answer to the requests that are given to me. Most of the musculoskeletal symptoms that we are treating are experienced when the patient's in activity. And this of course means that the patient is often upright with gravity acting in head to foot. Which seems daft then when you look at most of our scanners where the patient's lying down. For me, real-time motion is often very important when I'm trying to get some clear information about what's going on, because there's a very complex interplay between the activators and stabilizers in the joint or in the spine, and either of these areas can be a cause for pain. A specific activity pattern may also be a cause for pain, and I want to try and interrogate the patient when they're doing that action. And also a specific position might be the painful one. So any imaging test I do, I want to try and replicate, why is the patient hurting, rather than just putting them into a default lying down position and image them. So some of the limitations I find with the current techniques that I have available is that you can get overlap of complicated structures, bony overlap, overlying soft tissues and so forth. A lot of the imaging techniques I use may be too slow to capture real-time motion. I can't see all the structures. I have to trade off whether I can see soft tissue or bone. And it's often very difficult to actually use the machines that we've got to put the patient into the position of pain or into a position of load. So this is just, if you like, an overview of the techniques that I currently have when I'm trying to answer a clinical problem. And I'll just go through these by way of introduction before we look at what the CT can do. So conventional X-rays, obviously we've had them around for more than 100 years now, so we understand a lot about what they can do, but of course it's static positioning only. And we get a lot of overlap, bony overlap. We're having to try and tease out a 3-dimensional view from a 2D flat image. I can't see what's happening with the soft tissues unless they've calcified, in which case I can infer there's trouble, but I can't actually see the soft tissues themselves. We can apply artificial stress, like looking at stress views of the ankles and so forth, but that's not really using the primary activators and looking at the joint in its physiological state. And sometimes we can actually add some load, like we can do holding onto a weight and imaging the acromioclavicular joint to see if the joint subluxes, or we can do standing X-rays to look at what's happening to the arches of the feet when we stand. So there is some insights there, but they're not as full as I might want for my purpose. Going to the next level and using screening X-rays is quite good because I can actually now stand the patient up, so I can add the gravity and I can get the patient to move. But I still get a lot of overlap. I'm still looking effectively at a 2D image, and I still can't see my soft tissues. CT is great because it's taking the X-ray and rotating it around the patient, so I'm automatically getting rid of overlap straight away. But again, because the patient's lying down on the table, I don't weight load the patient necessarily, and it's difficult to get true physiological motion again. And with a CT scanner where I'm rotating the X-ray tube, I have to move the patient on the table through the hole in order to be able to build up the CT image. So they have to lie still. If they don't, we can get misregistration in the images. I can, however, continually image a thin slice, in a repeat loop. But of course, then I've got a very small coverage. So I'm still struggling to get a real answer. Now, ultrasound is great because we've got real-time capability here. It's scanning all the time, and I can put it over the area of interest and get the patient to move it and try and see what's going on. I can scan them whilst they're in pain or in a stress maneuver, and I can get additional functional information, and also I can use it to direct therapy. I can see where I'm putting the needle, for example, into the subacromial bursa if the patient's got a painful shoulder. My real problem, again, though, is that I'm limited to the soft tissue structures this time rather than bone. The ultrasound can't penetrate through bone. Also, it can only penetrate a certain distance through soft tissues themselves. So getting in-depth penetration in large soft tissue structures like the spine or the thigh or the pelvis can often be very difficult. And I'm stuck with that limited field of view, which is as big as the probe head. There is a lot of intellectual challenge to being able to correlate what the ultrasound is showing you with the physical state of the patient underneath you. I often call ultrasound an extension of the examining hand, and that's because I've had a lot of training. And when you train someone in ultrasound as a clinician, they often will get it. But there is an intellectual challenge there, and there's a technical challenge as well to be able to scan properly. And if you're trying to, say, scan a shoulder whilst the patient's doing that, you'll find it's difficult because the probe head will be kicked off by the motion. So maintaining that skin contact can often be very challenging. So it might sound easy, but actually when you try it, there's a few hurdles to overcome before you can be successful at it. And by way of illustration, I've just put a couple of little AVIs here. Now, just so that to orientate you, this was a protocol I was using to look at causes of groin pain. Now, this is the patient's head end here, feet down here. And what you're looking at here, this is the anterior border of the symphysis pubis. This is the rectus abdominis musculature coming down to insert over the front of the symphysis pubis here. And we're down into the thighs down here. And this is the peritoneal cavity at the bottom. So at first I was looking at herniae coming through slightly more laterally, but this is close to the midline. And it was interesting when I got the patient to cough and just watch what's happened to the symphysis pubis here. It doesn't move hardly at all. Now, that is a normal patient with normal pelvic stability. So again, if you watch when they cough, keeping your eye on the front of the symphysis there, there's hardly any deflection at all. That's a coughing maneuver, which I'd adapted from looking for a hernia coming out. This is a patient who had known poor core stability, and we asked them to do the cough maneuver without turning their core stabilizers on. Again, so you're orientated, that's the anterior border of the symphysis pubis, the rectus abdominis muscle coming over to the front of the symphysis there. Watch that area there as I play the video as they cough this time. This is a patient. Okay, fine, that's interesting. What's going on there? And I got really interested in this because I did a lot of work with groins and trying to find out why these patients develop these tears that seem to come from the front of the symphysis by the pubic tubercle going back into the inguinal canal. And maybe this is a bowstringing concept. Maybe patients who have poor pelvic stability are constantly overstressing that common adductor and rectus aponeurosis over the front of the pelvis and starting to peel off from the front of the pelvis. So you can see how using something like ultrasound here is helping me to gain, if you like, a little bit of a functional insight into why patients are generating these pathological lesions that surgeons later go in and repair. But as you can see, I can't see through bone. It's a pretty sort of low-res image. You have to believe me when I tell you what you're looking at, but it could be anything, couldn't it? Okay? So, you know, it's a big intellectual challenge. So really, I'd like a better test than that, please, if there is one. Well, MRI is great. because it shows me both soft tissue and bone with equal capability. So for me, as a sort of, if you like, an applied anatomist, the anatomical detail I get is great, and that's what I love about it. The big negative is it's slow. We're still taking 1 or 2 minutes, even with the fastest scanners, to acquire an image set. And some people have tried to do things like patella tracking using so-called kinematic, where you image for a second, then move, image for another second, then move, and then putting into a cine loop. As far as I'm concerned, it's worse than useless, because you haven't got physiological movement. You haven't got all the muscles pulling in concert in that coordinated fashion in true real-time movement. And so I don't think that the information you get from that is reliable. Once again, for most MRI scanners, the patient's got to lie down, and you can't really scan them in a position of pain. You can try. This is what I call the abducted externally rotated position, or the stop sign, which a lot of patients get, particularly in the overarm throwing athletes or in the javelin throwers you see there, where they get that sudden catch of pain when in the shoulder. So sometimes, using an open MRI scanner, I can put the patients into this so-called APA position, and that's the imaging coil, and they're about to slide into the scanner there, to look a little bit more functionally, in terms of position at least, at what's going on. This is a wonderful medieval torture device. This is a patient where we're trying to get weight loading on the spine in a patient who's lying recumbent. And this corset device attaches underneath the imaging coil there, and these straps come down to this foot plate here, and you've got these 2 little dials, and you can dial in tension on these bands that pull down on the patient's shoulder to replicate standing. And you say to the patient, I'm going to turn these dials until it hurts, sort of thing, which is kind of nice. And then they have to lie there with the pain for about 5 minutes whilst we try and get a scan. Of course, they can easily just bend their knees to get rid of the tension. But, again, it's medieval. It's not particularly physiological, and we struggle to get to anything like the normal situation. Going a little bit further, some MR machines can scan the patient standing up. This is the Phonar upright scanner, but as you can see, it's absolutely humongous. It's very slow, it's very large, it's very challenging to run, actually, to get good images. But you can see the ends to which we will go to try and get some true physiological imaging in patients. So, what comes next? Well, what the purpose of the presentation this evening is to introduce you to the concept of dynamic three-dimensional volume CT scanning. Now, as I mentioned earlier on, initially the first generation of CT scanners, you had an X-ray tube rotating around the patient, so you'd generate a single cross-sectional slice in one rotation of the tube. Then someone had the bright idea, well, what happens if you continually rotate that X-ray tube but then motor the table through that rotating tube? Well, of course, you end up with a spiral acquisition, so-called spiral CT, and you could feed all that information into a computer and it kind of work out the misregistration that was occurring and give you a volume, but there was lots of so-called stepping artifacts. There were low-res imaging. So people started saying, well, let's do a helical scan or a spiral scan, not with just one slice being acquired, but several at the same time. And that threw us into something that I call slice wars, as manufacturers vied with it to say, well, hey, I can scan 4 slices at a time, and said, well, no, I can do 16 at a time. And so it went until we got to the 128 generation scanners, which were, until the Aquilian 1, the state of the art. Toshiba then introduced this 320 slice machine, so they're acquiring 320 slices of data simultaneously as the patient is being moved through the machine. But suddenly, if you think about it, 320 slices is quite a big volume of tissue. And in fact, what it allowed you to do is to disengage from this so-called slice paradigm to something I like to talk about, a volume paradigm. In other words, we're not imaging multiple slices stacked up. We're actually imaging a whole volume. Now, why is this important? It's important because it gives you the idea that you can actually now start to do three-dimensional X-ray fluoroscopy. Effectively, what you're seeing is that 320 slices represents a 16 centimetre deep cylinder of tissue that you can image in real time, or effectively every 0.35 seconds, which is the refresh time, the time it takes to do one rotation of the gantry to collect all that data. That's 320 slices of data being fed into the computer. Therefore, the table does not have to move. And that's an important concept, because suddenly it means that instead of artificial movement of the table, you can start to use controlled movement of the body part within that imaging volume, and that releases you from the restrictions that are placed on most scanners. It allows you to think about recreating painful maneuvers. You can try and get the patient into the scanner in a way that they're getting some kind of gravity loading on some body parts, and we'll see some of those in a minute. And then, of course, you need to have the advanced workstation that comes with this machine to be able to interrogate the torrent of data that comes out of the machine. And unfortunately, one of the limitations of this presentation here is that I can't show you what it's like to take a workstation and interrogate the volume of data in real time. But it's very flexible, and you can say, okay, what's the question here, and then hone in on the body part you're interested in. And I'll try to illustrate that with the following cases. So here's a proof of concept. This is a frontal view of a patient with a painful shoulder. And actually, we could already see signs of trouble here. There's a little lesion down there. A little piece of bone has been taken off the inferior glenoid. This, of course, is the clavicle here, the acromioclavicular joint, and the head of the humerus, and the coracoid process here. So we're looking at the shoulder from the front, and then we just ask the patient to do a simple maneuver to try and prove the concept, just basically internally and externally rotate their arm. And they were sitting, leaning into the volume of the scanner, so they've got gravity acting down, as it would normally do, on that shoulder, and they're going to rotate their humerus in real time. And this is what you get, and you can cine loop it, and you see this, that's real motion acquired in real time, gives you an idea of what we're starting to deal with when we're interrogating these data sets. Now, what you can do then is you can look at it from any position, and you can also slice bits away. And what I've done here is I've actually taken away the humerus just to leave the head of the humerus in location. And this, of course, here is the acromion process. And here is the subacromial arch height, and there is very narrow. And now what we're asking the patient to do is to do the thing that hurt them, which basically was this, okay, within the imaging volume. And as we play the video through, you'll see that, bang, what's happening is that part there, the humeral head, is coming and bashing into the acromion process and causing them pain. And as this was the painful moment in the whole movement cycle that I've kept for you here, bash, it's actually clonking into the acromion process. That subacromial arch height is being completely lost. So they'll be pinching the bursa and the cuff there, and that was why it was painful. But you can see the total imaging volume here from the mid-cervical spine almost down to the bottom of the scapula. That is the patient leaning into the volume, that cylinder of scanning volume that I talked to you about, 16 centimeters deep. So then we can put any other body part that will fit into the scanner into that imaging volume. And this is a patient with anterior ankle pain. And it'll be fairly easy to see. If you keep around this part of the ankle here, you can already see a little spur here. And you'll see, as they go through a range of dorsiflexion, clonk, that little bony spur is coming up and impinging on the anterior margin of the tibial plafond. Now, that, of course, is diagnostic in itself. And looking at CT scans as I do all the time, I'm used to that, and it's easy for me to appreciate it. But it's kind of not really, it's not, if you like, an image that, say, a patient or a clinician who doesn't look at a lot of CT scans can easily visualize what's going on. Far easier, I would say to you, to look at the three-dimensional build-up on the workstation. This is the frontal view and the side view, and now you can see this bony bump here. You can see it here. As I play these AVIs through, now you'll appreciate, you can see how that impingement is working. And so as a surgeon, you could show this to your patient and say, look, that's the problem, and I'm going to go in and I'm going to take that little bony bump off, and you'll get better. And I think there's a lot of power in medicine by being able to show the patient in a way that they can easily accommodate and understand what you're going to do to them. And this is probably the clearest thing, short of actually letting them look at their own operation, that they can appreciate what you're going to do to them. So it makes that explanation a lot easier, I think. Getting into deeper structures is often a challenge for imaging. We need to be able to get rid of overlap. We need to be able to see what's going on. And in particular, at the base of the skull, you've got a lot of overlap in the jaw, the base of the skull itself, the cervical spine, the soft tissue structures, the vessels, and so forth are all there. Now, this was a patient where we really just wanted to see what was happening to the atlantoaxial distance. We were worried that there was some instability there. But when we did this study, just in this conventional 2D representation, we could see that the atlantoaxial distance there was not significantly altering. This was another patient where we were looking at cervical spine dynamics, and this is the only one I'll show from the neck, really, because Nick's going to talk about that to you later. But again, we asked the patient to rotate their head, and this is the patient leaning into the scan volume, so they've actually got some gravity, the weight of their head acting on the neck. So we're trying to recreate a real physiological situation. And most of the rotation, as you can see, is occurring at the top here. This is dysfunctional motion. They've got very limited motion in the lower cervical segments. As I run that through again, you'll see they're pretty splintered low down, and at the top, there's kind of excessive rotation of the head. So if you like, it's an accommodated movement. It's not a true physiological movement. But there's a lot of learning curve to this. We have to know what normal looks like first, and I need to work with my clinical colleagues who can say, oh yeah, that's clearly abnormal, and that corresponds to what I find when I examine them. So it's the same old story for me as a radiologist. I have to piece together the story by extending my knowledge out to what the clinicians need to know or have learned, so I can give them back a meaningful answer when I do my report. Again, this was a patient who'd had a repair done of their dens, and we needed to know, is the repair stable? Is the atlantoaxial distance here staying stable as well? Because the patient had a lot of pain. So we needed to know that those two things weren't causing pain. Difficult study, this one. There's a lot of kind of misregistration artifact because the patient was wobbling because it hurt them so much to do it. But by the end of it, and once I'd looked at it often enough and looked at it in multiple planes, I was happy to say the repair is stable and the atlantoaxial distance is also stable. We have a big interest working with the lumbar spine, and often the question is, what's the status of the spine? Is it stable? Where's the pain coming from? And a simple three-dimensional view here of someone who's had a lot of fusion surgery. You can see they've got interbody fusion there at L4-5 and L5-S1. There's a nice view down the foramen. As we come around, we can see these big bone blocks here of the posterolateral bony fusion. There's been a posterior decompression. You can see the big foramen there where the spinous process has been taken off. Another view of the foramen coming in here. And you can see what I've done to make this. I've actually, on the workstation, I've cut away the iliac crests. I've cut away the overlapping structures. And you can spend hours and hours making these pretty pictures. But, you have to think about what you're doing. Also, that volume you're seeing there, I can tumble in any direction in space. So I can look down individual outlet foramen. And just you can spend hours interrogating the data. But this is just a simple spin through to show you, where I start from. And the question is that patient stable or not? And we started doing flexion and extension studies in the scanner, effectively either a press-up for the extension or a sit-up for the flexion. And I know Nick wants to talk a little bit about this sort of the pump action that we see going on in the soft tissues anteriorly, but this is the extension maneuver, and here's the flexion maneuver. And you can see the change there in the abdominal contents in the hollow viscera. But critically, all these levels, I'm quite happy to say, as far as I can see, that's a stable fusion. When we get into the realm of abnormal motion, things can become more complicated. This is a patient who has Harrington rods, getting a lot of pain, and the question is, how do we manage the abnormal motion segments? What's going on there? This is a patient doing flexion, and you can see there's quite a lot of abnormal rocking motion at the L4-5 level there. Here's the bottom of the Harrington rod, and already now you can see that there's almost like a rocker bottom of L4, gaseous degeneration of the disc, and when I run the movie through, again, you get a much more convincing feel for the collapse of that disc space and the abnormal motion, the rocking motion that's resulting from the rigidity of the motion segments above, leading to abnormal motion through that motion segment. So I'm able to interrogate levels in a much more confident way than by any other technique that I've got. And then you can really hone in on particular areas. This was a question, this is the pars intra-articularis. The patient had low back pain. We'd done conventional CT. We knew he had pars defects, but the question is, are they stable? Well, it's very difficult to say, and certainly you can't do fluoroscopy because of the overlap. And I looked at this one, and I thought, well, maybe, I'm not sure. There's the pars defect coming in there. Looking at it multiple times, I'm not quite sure. But I used a slightly different orientation because I can vary the orientation in real time when I'm interrogating the data. These AVIs are just, if you like, snapshots. There again is the pars defect. And I think when you look at this one, you'll see it kick there at the end of motion. If you look at the anterior border, if you follow this anterior border here through to here, as we go through, you'll see it kick backwards there. and that's an unstable pars defect. So I was able to actually come back and say, no, in real time, when this patient does a sit-up maneuver, which was hurting him, by the way, position of pain, I can see this pars defect actually hitching. So it is an abnormal pars defect in as much that it's unstable. So we're able to refine the diagnosis in these problematic patients. And we're also able to refine the diagnosis in common or garden patients. This is a patient with known facet degeneration. She's got quite debilitating low back pain, which has suddenly flared up. What's gone wrong? Has she developed disc pathology? Well, when she does a flexion, you see pretty much that the lower motion segments are very splintered, hardly moving at all. Maybe we should expect that with the facet disease, but it's not explained to us why she's got pain. Certainly doesn't seem to be coming from abnormal motion in the disc spaces, because they don't seem to change barely at all. When we did this, we could see these big furry facets, which are her degenerate facets, and I thought, well, okay, they don't seem to be moving very much. And then my eye fell on something else, which is here. And if you look at this area here, you'll see there's just a faint band. If you keep your eye on that, suddenly click, it opens when she went into flexion. Again, that's explaining why she developed sudden pain. She actually fractured her pars. So in amongst all the overlapping disease, all the overlapping degeneration, I was able to hone in on a particular area and actually see an unsuspected pathology that was contributing to pain. So for me, this is the real power of the technique. It allows me to take what I already know from all the other tools that I'm using and refine problem cases, and they needn't be complex. This is a common or garden problem. How many patients do you see in your practice with lots of degenerate changes in the lower lumbar facets, and then suddenly they decompensate one day and they come and say, my back's got much worse all of a sudden? Trying to find out why can often be difficult, but the power of this technique, I think, can help you to determine unsuspected pathology and hopefully then come up with some kind of treatment routine for them. So for me, in summary, this dynamic volumetric CT for me is opening new windows into both common and complex pathology. It allows me to attempt to image in a much more functional way than I have been able to before. I recognise that there's a steep new learning curve to climb, and I need to continually talk to my clinical colleagues to make sure that I'm not making things up, which is very easy to do. I have to make sure that I'm respecting the dose limitations, because we all know that CT is so commonly used now. But I think if you're using it in a focused, targeted sense, it is legitimate. And I think that this kind of functional imaging, trying to add gravity, trying to add functional positioning, is the way forwards in musculoskeletal imaging. So in summary, I'd like to thank Paul Jenkins and his colleagues, and particularly Tony and Mike and the staff at the European Scanning Centre for allowing me access to the scanner and helping me to develop these protocols and sequences. Without them, none of this would be visible. And as I say, it's a team effort, so thank you very much indeed. What we're going to do now is to move on into another area, which is to introduce to you Dr. Marcus Banks, who is a consultant orthopaedic surgeon at Guy's and St Thomas's Hospital, who's going to look into another area where symptoms are common, the hips, but we're looking at new pathology in the femoroacetabular impingement story. And whilst you just get yourself set up for... Very good. Marcus, of course, is using an apple. This is one of orthopaedic surgeons.
And here I am starting straight away seamlessly as a result of that. Good evening, ladies and gentlemen. Thanks very much for inviting me, Paul. I'm going to talk to you about femoroacetabular impingement. It's all the rage in hip surgery. At last, we have answers for some of our younger patients who actually have hip joint pain, whereas previously we didn't have the means to either diagnose their problem or indeed treat it. And I'm confronted really with an epidemic of young adult hip pain. They're often parents, they have jobs, they're in employment, they're educated, they clearly have access to the internet, to YouTube, and they're quite often parents of young children. And what they're struggling with really is not only can they not exercise to the extent that they would like to, but also they can't really actually live their day-to-day lives. They get a lot of discomfort, say, sitting at a desk, or maybe standing on a train on the commute to work. So these aren't trivial symptoms. These are symptoms that do affect patients' day-to-day life. In addition, this sort of huge emphasis on recreational activity, both in the media and obviously by the government as well, makes them feel even less happy about not being able to live such an active life. Now I'm just going to talk to you about normal hip movement and ideal hip movement, and then compare it with the kind of things that go on in impingement. These are a couple of individuals with ideal hip movement. This particular unpleasant individual, I'm pleased to say, is retired from cricket, but he's been replaced with an equally unpleasant one. So this is a cartoon, if you like, of the hip joint. Here's the socket, here's the ball, here's the femoral neck, and this yellow thing is the acetabular labrum, and the brown thing is the articular cartilage. So a normal situation when the hip flexes up, hip moves, and everything's great, and that's what we all like and expect. Now this young lady is actually a professional ballet dancer who's hypermobile, but also you'll see she's got quite a narrow neck relative to her femoral head. And in fact, if any of you ever looked after ballet dancers, they've all got pelvic x-rays like this. You cannot be a professional ballet dancer without hips this shape and without being hypermobile. And so her hip, rather than going that far, will just go that extra bit more because the femoral neck is a little bit narrower. And also, obviously, she's hypermobile, so she'll go that bit much further again. You know, if you take this individual who's a professional rugby player, this is sort of the opposite end of the spectrum, really. Very thick femoral neck relative to the femoral head size. And therefore, this gentleman, rather than getting that far with his flexion, will actually not get quite as far. So he's intrinsically not going to have such a good range of motion. Now, what is impingement? Well, impingement is an abnormal and repeated contact between the front of the femoral head-neck junction and the edge of the socket. And you get this sort of conflict in this anterosuperior area. And as a result of that conflict, you get damage to the acetabular labrum and you get damage to the anterior articular cartilage. And it's due to shape abnormalities, predominantly of either the socket or the ball, compounded with an excessive range of motion. And you'll hear this terminology. You'll hear about CAM-type femoroacetabular impingement, which is due to abnormalities on the femoral side, and you'll hear about pincer femoroacetabular impingement due to abnormalities on the socket side. Now, concentrate mainly on the CAM side. I learnt how to fix shelves and build IKEA furniture from learning how to fix bones. And in the same way, I've learnt about camshafts from the study of orthopedics. I want to know what it actually is a camshaft, given that I'm operating on cams the whole time. This is a camshaft from a North American muscle car, and the cam is this bit that extends from outside either a disc or a sphere. And when a cam rotates, it converts rotational movement into reciprocating movement, and I'll expand on that. So this is a hip, say, that's got a cam. This is the cam here. It's a non-spherical part of the femoral head. That's the non-spherical part. That's the cam just there on the camshaft. And when that hip flexes up, initially it just pushes the labrum out of the way. But what actually happens is the cam sort of catches on the front of the socket and actually produces shearing force on the articular cartilage. And in its early stages, it produces this sort of softening of the articular cartilage. That's the front of the socket. The ball's down here. That's a probe on the front of the hip socket. And that articular cartilage isn't really glued down properly onto the front of the socket. And those are the earliest changes you get in FAI. As the situation progresses, you get further damage to the articular cartilage and you get these subchondral cysts. What also happens is the acetabular labrum becomes bony. It gets fed up of being pushed out of the way, and so beefs itself up a bit, and you get a sort of a secondary conflict between the edge of the bony acetabulum here and the front of the femoral neck, a secondary sort of pincer phenomenon. And again, this is a sort of arthroscopic view of slightly more advanced cartilage damage, and there's a big sort of articular cartilage flap there. And you just don't see that on X-rays. You may see it if you're lucky on a scan. Now, just so I'd sort of extend the CAM discussion, really, this gentleman maintains this static engine. This is at Pickering Steam Fair. And he's got, this is his engine whirring around. There's the camshaft. And I just thought that's quite helpful. You imagine sort of every time a patient flexes their hip, you're getting that sort of mechanical conflict. And it's easier to see in slow motion. Ow, 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 ow. 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 You can imagine that happening, ow, every time the patient's getting up from a chair. So where do these cams come from, and what are they all about? Well, it's interesting that by doing comparative anatomical studies, you can actually see that actually cam-shaped hips are actually normal in four-legged running animals, such as horses and even hopping animals like kangaroos. And if you're on four legs, actually having a cam is quite a good thing in terms of allowing you to run. The trouble is if you stand on two legs, having a cam isn't maybe such a good thing when you need to flex your hip more. The ballet dancer's hip is this so-called coxa rotunda, is seen in climbing mammals exclusively, and say that's an orangutan hip. Clearly, if they can't flex their hip absolutely perfectly, then they're not going to be able to survive as an orangutan. So the flat femoral head has been selected out in orangutans in the same way the spherical femoral head has been selected out in running animals. Unfortunately for Homo sapiens, both patterns exist. And as well as there being this sort of developmental predisposition, these bumps actually develop in adolescence. And these are actually a sequence of radiographs. The patient brought them in. He's 35. I've done both his hips for impingement. But this is his X-ray when he's 7, and this is when he's 9. And he's clearly, if you superimpose the circles, he's clearly got a cam here, and he's got a cam here as well. And as he's sort of growing older, the cams become sort of slightly more prominent, and that's the situation on a 3D CT. You can see that sort of prominent flat area. And he's done very well from bilateral surgery. And of course, as well as causing pain in day-to-day life in the early stages and inability to exercise, we're fairly certain, although we'll never prove it, that eventually these lead to osteoarthritis. And there's a nice big cam there and a totally wrecked hip. And he's got a smaller cam on that side, and probably in another 10 years' time that'll go the same way. That's what you do for that these days. So let's just talk about pincer impingement. The cams, I think, are quite easy to understand because there's a clear and defined shape abnormality of the femoral head-neck junction. On the pincer side, it's a lot more smoke and mirrors, so it's a much harder diagnosis to make. And we still haven't quite cracked it, I don't think. But here's our normal hip movement. And so there, we're not getting any conflict at that point. But imagine if you've got a hip socket that's deeper than usual or where the labra have become ossified. You can then imagine that even during the course of normal hip movement, you'll get abnormal conflict in this area. And that's the so-called pincering. If you like, the pincer is the lobster of the socket and the femoral neck is the finger there. And another situation you get it is when the socket points slightly backwards, so that you get conflict between the front of the femoral neck at the socket during normal ranges of hip movement rather than in excessive ranges of hip movement. And pincer impingement does exist, may be subtle on X-rays. It's certainly, there's nothing wrong with those X-rays. Simon may disagree, but on the shoot-through lateral, you can see there's that big divot where you're getting that pincering going on in a big groove at the front of the femoral neck. And it's even clearer to see in this simulated rather than real 3D view. So why does FAI become symptomatic? If I'm telling you that these patients have had the deformity all their adult life, why does it become symptomatic? Well, it's cumulative damage. They play sport, they flex their hip, they load and twist their hips progressively, and then eventually the straw that breaks the camel's back, as it were, the labrum tears. And when the labrum tears or the articular cartilage gets damaged, then it becomes painful for the first time. And that's really the beginning of the end. And again, you're more likely to get symptoms from impingement if you've got a big range of motion, as I mentioned, the hypermobile ballet dancers, if you've got a big bump, if you've got generally genetically poor quality cartilage that's less able to withstand this kind of problem, and clearly activity level is very common. And almost all my patients, presenting in their 30s, there's always a history of almost always a history of quite significant sporting activity. They play rugby or, they regularly play football or something. There's always something in that. And obviously, if you've got a big cam and you play elite rugby, you can run into trouble in your 20s. So what are the clinical features of this? Well, it's groin pain, and it's an insidious onset of deep groin pain. And they may get associated catching or locking with twisting manoeuvres. It may catch getting up from a chair or twisting in a certain direction. Quite often they may be able to still run, but what they can't do is change direction, because anything involving loading and rotation will cause that femoral neck to catch up against the acetabular labrum. One rather eloquent patient described, I'm intolerant of sudden angular movements, he said. He was a lawyer, but, great. If patients tell me that, then I know what's wrong with their hip. Classically, it's worse getting up from a chair or getting in and out of a foot. And I'm sorry I'm no longer on the video. But when you get up from a chair, you actually flex your hip quite a lot. And you know, sitting comfortably at your desk. But when you want to get up, your hip's going to flex, you know, to 120 degrees maybe. So they get the catching just there. And they may sort of take a couple of steps to shake it off. And the other thing they may notice is, you may not notice it, they may not notice it, but you may see them in the consultation looking a bit casual, you know, and they're looking casual because they prefer to slouch, because sitting upright is actually sore and catches their labrum. Recurrent groin strain, it can be a presentation of FAI. I saw a chap today who's had surgery for Gilmore's groin, and sort of as things have panned out, he probably never had Gilmore's groin. He probably has always had impingement. Patients may describe that they've changed their exercise type and they've had to stop running but are still okay on a bike. But when you're getting this kind of stage when they can't have a kick about with the kids, that's when I think you've kind of got to do something really. Usually non-surgical management eventually hasn't worked. It may work initially and with the inevitable delay in diagnosis. And I suppose what did we do before impingement? Well, we just weren't aware of its presence. Certainly fewer patients had it because they were doing less exercise. There was no effective treatment for it, and if there was just a little bit of so-called early wear and tear on the hips, they were just told to wait for a hip replacement and that they were far too young for it. And patients just put up with more and just took pills and just were told to go away. Fortunately, we can do better with that. Examination findings can be subtle. The C sign is if patients describe their pain using the sign language letter C, clutching their hip like that, that's hip joint pain. Occasionally you get the concept of coordinate fingers. Sometimes patients take two fingers. My pain is deep in there. It's where these two fingers sort of converge. And again, it's a very characteristic story when you've heard it a few times. By and large, the range of motion in the hips is preserved, but there'll be a decrease in internal rotation and flexion, and they may have a positive impingement test. I'll just talk to you about the impingement test. In what you're trying to do with this is you're trying to recreate the pain that the patient's describing by jamming the front of their femoral neck up against the edge of the hip socket. And so what you do is you flex the hip up gently, which may produce, when it's its most weakly positive, you'll only get pain when you both flex, adduct, and internally rotate the hip. So you first flex it up, then adduct it, and then when it's most weakly positive is when you internally rotate it. Some patients get pain with flexion and adduction, and you don't even need to internally rotate it to reproduce the pain. And some patients, very irritable patients, will get pain in deep flexion. The 3D scanning, really, we've scanned actually Simon Blease's hips because Simon does have deformities in his hips. Nowhere else, I hasten to add. But Simon does have some cams, and we put Simon through the scanner, and this is his scan, and we're doing the impingement test on Simon here, and you can't see his cams very well, but that's where his cam is. And again, we're just very much feeling our way with this technique in impingement. But you can see there's the bump, and it's grinding on the inside of the socket. And what you may notice, of course, is how much movement, how much the pelvis is moving. And this is what's really exciting. There's the scanner again. And this is a sort of a front view of it, going on, sort of supporting Simon's comments about being able to interrogate the data. We're now looking at him from the front. It's the same data set. But you can see how much his pelvis is tilting, and so you can see this complex interrelationship between the tilt of the socket and the impingement itself. The socket's trying to get out of the way, isn't it? You know, it's trying to lean out of the way of the sort of the cam coming towards it. And this is why the diagnosis of pincer impingement is so difficult, because the orientation of the socket varies so much during normal day-to-day activities. So obviously we need to talk more about imaging. Plain radiographs remain very, very helpful for this condition. The eagle-eyed amongst you will just see that little thing there. And if you superimpose the circle, you can see that bit is a cam. It's sticking out. It's small, but in a patient with hip joint pain, with his reduction in internal rotation and flexion, catching getting up from a chair, that is highly, highly relevant finding. But the real most useful, another very useful X-ray is a proper shoot-through lateral X-ray with a hip in maximum internal rotation, and it really shows the head-neck junction into profile. A standard frog lateral is often not very helpful, really. And again, this is this chap that we just saw with that very subtle thing. But this is his right hip, and if you superimpose circles on these, you can see that bit is outside the circle. Yeah, there's his cam just there. Whereas that side, on the left side, the asymptomatic side, without the little bump, it's all within the circle. So it is as subtle as this. And I think orthopaedic surgeons are only just sort of getting used to this degree of sort of diagnostic subtlety, even with tried and trusted X-rays. But X-rays I find extremely helpful, and there's the arrow just to help you all. This kind of thing is some ossified labrum, and again, it's a sign of unhappiness in a hip, really, and either a labral tear or a labral tear associated with impingement. And again, in a patient with hip joint pain, that's highly relevant. And is an indication for further imaging. I use MRI mainly to exclude non-acetabular rim conditions, because by and large, if the patient's symptoms are bad enough, they've had them long enough, and they're coming from the hip joint, I'm going to arthroscope them with or without doing some impingement-type surgery. So I'm very keen not to arthroscope people with diseases that are masquerading as impingement, such as that, which is a stress fracture. It's also nice if you see labral cysts and labral tears, but I don't usually use contrast because I'm a hip arthroscopist. I think if you really want to see the articular cartilage, the best way of seeing it is at arthroscopy. However, if you don't have arthroscopy in your sort of young adult management, and there are some of my colleagues out there, then using contrast to look at the articular cartilage is very helpful. These are plain MRIs. This shows some anterior articular cartilage cysts. That's the front, that's the back. Correct me if I'm wrong, Simon. But there's some cysts in the anterior acetabulum. And again, this you can see, you've all got your eyes in now. You can see a big cam there, can't you? Yeah, really flat there. You could almost put a ruler along that. There's no way that's going to fit nicely into that hip socket. But you can see that there's a little labral cyst. A little bit of increased signal in the subchondral bone there associated with impingement. I love CT. I love it even more now. We can do CT movies in real time. It's really, if you're really serious about impingement, you've got to use a lot of CT. It shows you the bumps very well, but it also shows you some anterior chondral cysts from damage from the bump, and this is the point of impact between the front of the socket and the front of the femoral neck, these sort of characteristic impingement cysts that you see at the front, at the neck. And these are very good little signposts when you're doing arthroscopic surgery and you find the cyst. These are less sophisticated 3D views, but you can see the bump there. It's sort of triangular, really. You can see it's sort of got a triangular kind of shape to it, the cam. Again, these are simulated movies. These are not real movies. This is so you can see, because we know it's simulated because the pelvis isn't moving. Because we know in real time, having seen Simon's one, that the pelvis does move. But this guy's got a cam here, but he's also got a little segment of ossified labrum there. So it's really going to hurt when he flexes up. You go, a bit like the cam. Ow! Yeah, can you see? That's really going to hurt there. And sure enough, if you remove that, it stops hurting, just like the ankle that we saw. So why operate on impingement? Well, the main reason to operate on impingement is because it hurts, and it stops people sitting at their desks, and it stops them running around. It stops them even commuting into work sometimes. So that's why we do surgery for impingement. Quite often the patients feel that the hip moves a bit more smoothly. You can't measure it, but they feel it's a subjective improvement in movement. Clearly, if you're improving the mechanics of the hip, it's likely to delay wear and tear or even prevent wear and tear in the hip completely. But I never sell it to patients like that, because you'll never be able to prove that. You're not going to put 100 patients in a room with impingement saying, no, you've just got to suffer, and the other 100 patients can have treatment and then look at them 20 years later. That's never going to happen. So we're never going to be able to prove that. We can pick some surrogate endpoints, but it's never going to happen. And when do you operate? I mean, I think when it's worth operating on them, and it sounds simple, but, you don't just operate on everyone with FAI. It's not a life-threatening condition. I see the tip of the iceberg, really. The vast majority of it is managed by physiotherapists, by osteopaths, by general practitioners, by personal trainers. And, sometimes the symptoms can be reduced dramatically with just a change in exercise schedule, change in intensity. However, if those measures fail and the patients have the appropriate imaging and they have symptoms that are sort of encroaching on their day-to-day life, then, surgery, is something to discuss seriously, really. Another group that needs surgery are elite athletes, because clearly if they're getting any pain running around or trying to do their sport, then that prevents them being in the team and therefore preventing them earning their living. So you try and muddle them along through the season with maybe a couple of hip joint injections and then operate on them as soon as the season's finished, if that's possible. Otherwise, if the injection's hopeless or doesn't work, then you just get on and operate them so they're ready for the following season. It won't come as a great surprise to you that the targets of surgery predominantly are moving the bump, the cam, to give you a nice round femoral head. These are some pictures from open surgery. You can also deal with any rim prominences, microfracture any cartilage injuries, and deal with any labral tears as well. And the traditional treatment is sort of open surgery, where you dislocate the hip, you gain access to everything, reshape the head-neck junction, and it's highly effective surgery. And it's an operation I still do, predominantly on teenagers actually, because I think you can get a perfect correction and potentially cure them of this condition. And because they recover much quicker, and 6 weeks on crutches for a teenager is no big deal. It's a much bigger deal if you're 35 and got 2 kids at home and a mortgage. So I still do open surgery on patients with very big bumps, big deformities, big rim problems, and as I say, in teenagers and adolescents. And this guy, I probably would do this guy arthroscopically now. This guy is a professional rugby player in Ireland, and we did open surgery on him. It's worked very well. He got back in the team, and he's delighted with it. And you can see the ball is nice and spherical. But I'd probably do him arthroscopically now. It's just one to just sort of, you see he's still got a little bit of a prominence there on the other side. You're saying that's nothing. I can tell you it isn't nothing, and it's subtle, but it's there. So I'll finish off just by talking sort of a bit about arthroscopic treatment of this. And clearly it's a huge advantage for everyone if you can do the same operation through little stab wounds rather than sort of a 6-inch incision. Certainly as you get more confident, you can take on more and more stuff arthroscopically. And it's my sort of standard operation for impingement now. You don't need to dislocate the hip. They're only in hospital overnight. If I did them in the morning, some of them could go home in the evening. They're on crutches just for a couple of weeks. Clearly, hip arthroscopy is a hassle. There's all this stuff in the way. It's a small, deeply located joint, and you need lots of kit. If you've got... I cannot underestimate the importance of teamwork doing hip arthroscopy. Everyone needs to basically know what they're doing so you can concentrate on the surgery. Because if you have to really, sort the staff out, tell the nurses where every single little plate bit has to go and explain everything, it's absolutely exhausting. Fortunately, I spent the middle part of last decade doing that, and now I have quite a nice life doing hip arthroscopy. This is the kind of setup. The patient's on their side, the X-ray comes underneath. That's kind of distraction that you need on the hip. You need between 8 and 10 millimeters just to get your scopes in. We attach the foot to a boot and then wind it up. So again, it makes Simon's medieval torture device look positively pale in comparison. This is a medieval torture device, Simon, and I'm sure your hips aren't hurting at all now, having seen that. And this is here we're arthroscoping. You basically put needles into the hip joint under X-ray to make sure you're in the right place, and put a guide wire in, then dilate them up with cannulated arthroscopes. And that's just the needle at the front, so that's water coming out of the hip joint. And here we are with a bit of action now. So that's the shaver here, and that's the scope there. And then the 3 portals are here really. That's sort of redundant, but they're just for the photo really, water coming out of it. That's the scope there. And that's a radiofrequency device, just clearing the capsule so that we get a good view of the bump. So that's just 1, 2, 3. That's all it is. This is the kind of thing that this guy's got a fairly standard sort of impingement bump here. And this is the kind of view that we have. That's the sort of the articular cartilage there, flaps of articular cartilage. We're buzzing that away with a radiofrequency probe. It seems a bit, I think I'm a bit quicker than that now. It seems terribly slow when I watch this. I think I'll do that a bit quicker now. And then when you've sort of got rid of it, you make a nice sort of sharp edge around the edge of the articular cartilage, just to give you a stable edge so that it won't pick up again. You won't trip over the carpet, as it were. This is the lesion now. Here's the femoral head here. Here's the socket. There's the labrum, relatively undamaged, but you see you've got this sort of quite a sort of about a 1 by 3 centimetre sort of area of articular cartilage, and this is about of the edge of what I think you should do. And so what you say, well, why isn't that just arthritis? Well, actually, the rest of the hip looked fine. There's no articular cartilage damage of the femoral head. The remaining articular cartilage damage looked okay. This is a man in his early 30s. He's got a bad hip for someone in his early 30s with that amount of articular cartilage damage. But if you remove the bump and do microfracture of the sort of exposed bone, then there may be some hope, and there's nothing really better than that. Cartilage transplantation procedures for the hip are even more in their infancy than they are in the knee, and it's all very well growing articular cartilage, putting chondrocytes in, but it's getting that articular cartilage to mature and actually stick onto the bone that remains a problem. So this is now sort of a view inside the hip. There's the edge of the socket here. We've burred away the bump there, and there's a cyst coming into view. This is just, there we go, there's a cyst there. Can you see that? That's one of those impingement cysts I talked about. And they're sort of little like signposts, so like GPS waypoints almost, because you can see where they are in the scan, and you can sort of correlate them. We're sort of burring away. We're just sort of finishing off with the burring now. We've obviously done the majority of it. That edge is the edge of the triangular shaped sort of extension of the cam. I'm just really sort of dabbing it really and just sort of looking around. But I find it easier to look with the burr still running for some reason. I just find it sort of slightly easier. I feel I can just sort of dab little things and stuff. So that's just sort of coming to the end. And the other thing is that you can actually, when you've done the correction, you can actually watch it in real time. And again, just to orientate yourself, this is actually a left hip. This guy's a junior. He's just got on the European Tour, actually, professional golfer, and then his hip started hurting, so hopefully he'll start again in January. But here's his labrum here. There's the femoral head. That's where his bump was. And as the hip flexes up, it can be quite difficult because you lose your view as you flex the hip up. But you can see that the ball is sort of clearing the socket there. It's not sort of colliding with the labrum anymore. It's difficult to get a before and after because you don't get such a good view of this until you've cleared a lot of capsule. It's just the way you do it. You gradually sort of accumulate the situation. So I think, fully arthroscopic bump excision is clearly the way to go. I think it's underrated in terms of technical difficulty. I think when you start hip arthroscopy, you're sort of led to believe that within a couple of cases you'll be able to do bump excision. I can assure you that it's not. It's a long learning curve. You need to be pretty comfortable at getting scopes in and out, looking around the hip before we can get started on this. And I'm very jealous of my fellow and my registrar who I'm teaching to do this operation. And I wish I'd had someone standing over me as I was learning it. But you can get hopelessly lost if you're inexperienced, and there's a completely inadequate bump resection there, and it's sort of depressing really. Surgical navigation could help when you're on the learning curve. But again, the problem with arthroscopic surgery, it's very difficult to register the skeleton. So I think, in expert hands, that arthroscopic impingement surgery is reproducible in terms of getting rid of the bump. It's effective. Harris hip scores improve. And I think if you look at series, the series with the better results are those where they're not really doing it on people with arthritis. And clearly, the earlier you intervene, as long as you're not doing trivial surgery of trivial symptoms, the better your results are going to be. And I think one of the advantages of the arthroscopic operation is that if you've got a guy on the borderline between sort of bad impingement stroke early osteoarthritis, if you look inside the hip and it just looks too bad, then you can kind of bail out and say, sorry, mate, your hip's actually too far gone. Really, getting rid of your bump isn't really going to help you at all. And we may need to look at something in the future, such as an implant. I think there's been massive advantages in the understanding and diagnosis of patients with groin pain and hip pain in particular. And it's a common cause of hip injury in runners. And the great thing is that if you make the diagnosis, it's relatively easy to treat, and surgery is effective and available, and it's actually very satisfying. You've got to sort of X-ray the patients to death, really. I insist really on MRI, plain radiographs and CT. I think anything less than that, you miss things, and I've regretted not doing all three in the past, and that's why I get all three now if I'm going to operate on someone. And I think, don't rush into operating, though. The last thing you want to be doing is operating on every single impingement bump that you see. Far from it. The patients that get operations, as I say, the tip of the iceberg. Surgery is effective. If patients really need open surgery because you can't do what you need to do arthroscopically, please don't dabble with it. You know, under-treatment is demoralising. Having one big operation is less disruptive than having one small operation and then a whole load of ineffective rehab and then another bigger operation. So, you know, if you do need to do one big operation, and it's a conversation I occasionally undertake, you know, you've just got to take it on the chin and you have to persuade the patient that that's what they need to do. I think we've still got a long way to go in terms of treating the articular cartilage lesions. Certain flaps you can stick down. Microfracture is the gold standard really for articular cartilage lesions. And I think what we really don't understand is this definition of pincer impingement. And something like the real-time CT will really help us understand that, I think. Thank you very much indeed.
Great. Thank you very much, Marcus. That really gives you a very powerful insight into the kinds of things that I, as a radiologist, have to get my head around when I'm trying to report these studies. But equally, I get a huge amount of information coming to me from the other side of the problem, if you like, and the specialties allied to medicine who have a lot to do with these kinds of injuries, and particularly looking at physiotherapy and osteopathy and so forth, are absolutely vital to know what they're seeing, what their needs are, what their understandings are to these conditions. And it's a great pleasure now to introduce to you Nick Potter, who's an osteopath who I've worked with now for a number of years at the London Spine Clinic, and I think we kind of understand each other now, so. Just about. Anyway, Nick Potter, thank you.
Where do I just go? Hold on, so I've got nothing on the... Okay. Oh, is it sabotage me?
Yeah, I've sabotaged you.
You mackers.
There you go.
That's great, thanks. Well, thank you very much, first of all, for asking me to come and speak today. I think I'm afraid a slight deviation from what the advertised lecture I was going to give from disc problems, because actually having thought about it since we first talked about what I was going to speak about, I thought how incredibly dull, and if I had to sit there for half an hour, I think I would be bored simply about talking about disc lesions. What I thought I'd try and do is wrap up in one talk a little bit about what osteopaths do, because I know there's quite a mixed bag of people here today in the sense of GPs and maybe a few physios, osteos, guys, I don't know exactly, but try and sum up exactly what I think we do. I'm very lucky to work in a truly multidisciplinary environment, so I can tap into the know-how and knowledge of a lot of my colleagues, particularly Simon, who has been invaluable to me, particularly in my research with NECs, which is what I'm going to really speak about today. And I thought for the clinicians amongst you, it might actually be quite useful to go home with something that you might be able to use in your clinics every day, particularly diagnostically, which is a syndrome or phenomenon that I call the upper cervical syndrome. And it comes with a number of strange symptoms, but actually predominantly manifest in the neck as their cause. I've become strangely attached to this slide. This little girl is called Samita. I was actually reading the book on which this was the front cover. Rather strangely, it nicely slightly depicts what I'd like to talk about indirectly, the most phenomenal entity of the human body to use its balance systems, its musculoskeletal systems, simply to do this kind of thing. That is, in fact, her father's thumb that she's balancing on, and this was taken in Calcutta. Why I'm strangely attached to it is that, in fact, I looked inside the flyleaf of the book to see who had taken the photograph and see what it was of, and, in fact, very vaguely noted the name of the photographer and forgot all about it. Strange enough and quite spookily, the first new patient I saw on Monday morning was the photographer. And he very kindly, he was as spooked by the coincidence as I was, and very kindly gave me a copy of the photograph. So what are we going to talk about? A little bit of introduction. What does an osteopath do? But I promise not to bore you with that too much. But at how that links into this little phenomenon called the upper cervical syndrome, which is basically a combination of neck pain, disequilibrium, which is giddiness, waftiness, which very often I know from working with GPs makes them put their head in their hands because it's either something very serious or apparently nothing at all. And also cervicogenic headache, which commonly exists together and can very often mimic migraine, common migraine particularly. The causes and treatment, but then also a little bit about the role of the dynamic imaging. One of the things that we do as osteopaths is get serially fed up with being able to prove what we're actually feeling with our hands. And it's very nice to use this kind of technology to start doing that. And I'm sure many of the physiotherapists amongst us feel the same way. We have some of the most highly tuned images, if you like, in the form of our palpatory skills, but it's very difficult to prove it, but it's even more difficult to measure it. Why do most of our patients come into the clinic? Well, most of the time they're in pain, and this is a rather nice quote, I think, by a general from the War of Independence, and I think most of you would agree, but what it sums up is that pain is an experience rather than a sensation, and it is modified and modulated in the brain and everything else that goes with it, whether it's catastrophization or past experience, etc., all modifies pain, and more we're using drugs to change the way that we perceive pain and the different things that we can do, and obviously rehabilitation and therapy are very important in that. So what does an osteopath do? Good question. I could show you this, an incredibly dull and boring paragraph about what we think we do. I still don't think it's accurate. The only bit I would draw you to is the bottom thing. Treatment is often about, as I put it, unlearning old and abnormal patterns of physical behaviour, or engrams, within the tissues before re-educating them into a new and better one. So the concept of unlearning before you relearn. Sometimes rehabilitation in its own right is not enough. But moving on, this is what I think we do. What does that mean? I rather like this little quote, actually. I can't define it, but what I know what it is when I see it. That was by an American judge on pornography. But I thought it was rather nice. We treat function, in my view. If you take the orthopaedic surgeons, they're mainly the hardware specialists, and if you take the neurologists, they're the software specialists. I like to think that we're somewhere in between as technicians. We're trying to match up the subtle web that links all of those together, the actual way in which function really governs structure and not the other way around. And I feel that in general terms in modern medicine we're increasingly becoming more reductionist, more subspecialist, and losing that subtle entity that binds it all together. It's amazing what some people will put their bodies through, and as I'm going to talk about next, I thought we'd have a few. This is a patient of mine who came to see me some years ago. I don't know if you can see it close enough. He is actually a co-pilot on board I think it was an aircraft carrier, obviously I'm not sure which one. He has in fact tried to eject during a panic when the first pilot was meant to eject first, and these are the sequential photographs taken as he comes back on board. You can see that unfortunately the ejector seat jammed. He did in fact deploy his parachute at the back, and he's now sitting halfway out of the aircraft at some 600 miles an hour. Miraculously he managed to land. You can see his arms out the back here. He fractured T2, 3 and 4, but also a little extension fracture his neck, but believe it or not managed to survive that, any form of paraplegia, tetraplegia, and survived to tell the tale. Needless to say, I think he was mainly doing groundwork after that. This is another patient who took part in a ridiculous race at Goodwood called the Jalopy Race, sponsored, as you can see, by Lufthansa. And unfortunately, there are no brakes allowed in the event. And this is what happened as he came around the corner. There happened to be a sports photographer there, but he very kindly provided this as evidence of what he'd actually done to his neck. Amazingly, he got away without fracturing anything again. Obviously, American football, I worked in the States for a while. This is a rather nice image of what they call a helmet tackle. You can probably see that the mouth guard, which is still in his mouth there, is normally attached to the actual helmet. So you can imagine the hyperextension force. And interestingly, this phenomenon of letting go is not actually induced by pain, but is hyperextension and shock to the cervical cord actually causes this as a sort of letting go phenomenon. This one I particularly like. This was a gymnast I treated where, no need to say it, hypermobility was their issue. And lastly, this was probably the most miraculous of all, out in America in the Indy 500. And apart from 2 broken legs, he actually got away completely scot-free. I did a lot of my research in Formula One, particularly into necks, and was involved in inventing a thing called the HANDS device, which I don't think necessarily works very well, but it's designed in it to stabilise the head during crashes, but more predominantly during braking and cornering. And lastly, a catch that went wrong, but again you can see the impact and trauma to his head and neck. Again, miraculously, he was relatively unscathed. The trouble is that half of them, particularly if they're hard on the necks, like jockeys, etc., end up with this as a phenomenon, cervical spondylosis, with bony spurs, protuberances, cord compression, etc. But amazingly, all of these patients, this particular patient, despite these disc degenerations on scan and the beginnings of what looked like cord compression, actually has almost no symptoms at all after treatment, and the range of movement is almost completely normal. So I think we can depend too much on imaging and begin to treat the scan and not treat the patient. And all too often we can zoom in on things and not correlate it with our clinical assessment, which all too often is not really good enough. So the upper cervical syndrome, what is it? It's dysfunction in the occipito-atlantal axial complex, basically between C0, 1 to 2. There are secondary changes in the cervical muscles, predominantly due to pain induced by this dysfunction. The sternocleidomastoid and the suboccipitals and scalenes all actually shut down. And there's something else I want, a sort of confounding issue about the way neck x-rays are traditionally reported that I'd like to change the thinking on. And as a result, you get increased alpha neuron activity. These are proprioceptive and pain-sensitive active neurons, which feed into predominantly the trigeminocervical ganglion, which is a very large, long ganglion from the cranial nerve 5, which extends down actually as low as C2. So the body was designed to take in a lot of information through the cranial nerves from the neck as well. The causes, most classic causes, are the rear shunt in a car, the classic whiplash, and in fact the reason that I've postulated for why we see such a delayed onset sometimes in their symptoms is because in fact the neurological trauma, neuromuscular trauma to the suboccipital muscles underneath the occipital area doesn't take effect very often, sometimes days, months or weeks later, until they've got into a pattern of using their neck that they then get the pain. Very often they'll describe visual or even hearing deficits. Again, this is usually due to the complex neuroanatomy and the way that we use our upper cervicals to tell us where we are in space. So again, going back to the balance analogy, this really is the link in between the way the upper cervicals work and that we use our visual fields and our vestibular mechanisms to actually balance. Hence, the giddiness becomes a problem. Very often when I first started treating this, I couldn't believe that patients were saying, well, it's amazing, I feel better, but also I seem to be seeing clearer. And initially I couldn't understand this, but it is in fact true. And in fact we now know that it's from improvement in their accommodation reflex. Their pupillary dilatation actually improves because they can begin to target better using their vestibular mechanisms more efficiently. The hearing deficit is also related. We use a lot of our hearing as well as our vestibular mechanism to actually sight objects. So again, when we retrain these people, we very often put ear muffs over them so we can focus on particular parts of their retraining. The non-traumatic ones are tummy sleepers, people who sleep on their fronts, and the worriers, the type A's who clench their teeth at night. Very often, both of those are also secondary to a more traumatic response, so they're codependent. Very often, any unilateral occupations, people who sit in cashier desks going from right to left, looking across at screens that aren't central. Laptops are my big hate, and we're all beginning to use them more and more, but in fact what we do, unlike a desktop, is shear the neck. Flexion doesn't matter, it's the shear that's the problem. That advances degeneration in discs and the upper cervical problems much quicker than flexion. You can look down for ages with no problems, but you cannot shear. If on top of that you're slightly short-sighted or have a visual field defect, then you'll begin to squint very quickly. The shear mechanism comes on. Chronic poor posture, the forward head posture, which again is related to desktops, etc., and I will talk a little bit about that later. And very often people with sleep apnea, they're mouth breathers. Because they're mouth breathers, they hyperextend their necks at night to try and get air, and this contributes to obviously also snoring. Anxiety and hyperventilation is another thing that I'm very interested in because I think a lot of it actually contributes massively to this, but equally this causes the other. Hyperventilation, I reckon, is probably in 60% of the population. We all lead very stressful lives, and as a result, we begin to shallow breathe. If you shallow breathe, you shut down your diaphragm. If you shut down your diaphragm, you use your accessory muscles. They are not designed to be used all the time, and they shorten and they encourage forward head posture. Irritation to the suboccipital area makes them become teeth clenchers. It switches on the muscles of the face, and the whole thing becomes a vicious circle. So very often the reason you will see the people who are the type A anxious people who've got the headaches is because they're locked into this little vicious circle. This is just a thing I actually normally give as a handout, but it's a very interesting evidence-based document which is all the side effects of hyperventilation. And very often those patients who endlessly go around neurologists with strange pins and needles, tingling, etc., this is never considered. I've almost never seen it diagnosed in a patient, and yet so many of my patients come in and the first thing they need to do is to learn to breathe properly. Classically, they produce this foggy brain, dizziness, lightheadedness. And in ladies, when they're in their menstrual cycle, the increased progesterone actually increases the effects of all of this, which is also quite interesting. Anyway, moving on. I won't bore you with this. This is all obviously the actual physiological aspects of hyperventilation. I've put them really in for the handouts more than anything else. The symptoms of the upper cervical syndrome are headache, which are very often quite long duration, and it very often mimics migraine. It will come with dizziness, and it can often make them feel sick, where they probably usually aren't actually sick. Usually they will get a hemicrania, a facial pain, which is usually one-sided, and it's very often occipitofrontal, again mimicking a migraine. They will often even say that exertion, coughing, sneezing, valsalva will also aggravate it. They very often will get TMJ pain, which can actually mimic what they call otalgia, so they tend to get an earache, which again often gets referred to TMJ and ENT specialists, but very often gets missed as a cause, particularly if there's no inner ear problem found. Misty vision, wafty headedness, disequilibrium. They say I don't get gross vertigo, but when I turn my head quickly, the world sort of follows a split second later. I'm unsure of stairs. I just feel unsure of myself. And they very often get tinnitus and hyperacusis. Just to remind you of the anatomy, the most important area is up here, C0 to C1, 2. These three groups of muscles just here have nearly 1,000 times more proprioceptors in them than any other muscle of the cervical spine or the rest of the body. This is the gyroscope, if you like, of the whole of the body. And a lot of evidence is showing that it actually sets the posture for everything beneath it. So the ground reaction force they pick up from the feet is then set and reflected by what these things are picking up. That's why when you see scoliosis patients, it doesn't matter how twisted they are, their eyes will always be on horizontal, because this detects it and sets the neck accordingly. The major one that isn't particularly noted on that slide, I'll just move on to the next one. The interesting finding that I'd like to have changed in the radiological world is this, the loss of the lordosis. How many times do we read on an X-ray or a spinal MRI like this that the loss of lordosis is due to muscle spasm? It's complete rubbish. The loss of the lordosis is in fact due to muscle shutting down, not the opposite. Most of the injuries in posterior whiplash causes damage to a small muscle here called rectus capitis posterior minor, which actually has a small fibrous bridge that attaches to the dura. That's a major finding because its process is actually to hold the dura back during flexion extension movements. If the posterior muscles are damaged and they atrophy, the C1-2 complex actually shifts forward into extension. The mechanism by which that happens then sets off shutting down of the anterior cervical muscles and the posterior ones, the deep multifidus stabilizers, and they very quickly become uncomfortable. Very often, they don't get any pain up here. They will tell you the pain is all around the facet joints of C5-6 and C6-7, and very often in a lot of other MRIs, the classic is the loss of lordosis and C5-6 disc bulging. The disc is not your problem. The disc is the effect. The problem is up there. Very often we'll treat endlessly the C5-6 disc, which has become hypermobile and being overused. You're recruiting a range of movement that should be done up here. 50 degrees of rotation comes from C1-2. 50 degrees, that's almost all rotation. The other facet joints down here are not designed to rotate. So if you start recruiting them, things break down. This is another example. Again, these are just more images of this flattened lordosis. But the consistent sign you'll also see is actually extension at C1-2. This is locked in, and that becomes basically blocked in its movement. And that is what I treat. It's that simple. The trouble is, if they've had it long enough, they get the secondary changes. This is just to show that little cross bridge that comes across from the back of the muscle. And if the forward head posture of laptops, etc., becomes exaggerated, this actually shuts down. It is not used to extend the neck. It's used to govern and monitor movement of the C1-2 complex. So it has a very, very specific. Again, this is more anatomy I won't bother with. These are the muscles that shut down. This is the anterior aspect of the cervical column. And these longus colli muscles are the ones that settle down. You can also see with the superior cervical ganglion how much sympathetic involvement anatomically and how important these are, which is why you get feed-in centrally to the brain and you get all the other strange associated symptoms. Again, more anatomy, which I won't bore you with, but very often you also get involvement of the C2 nerve root here, which also can give you a C2 headache, which is again the side of the face, etc. And that is due to the extension of the neck, upper neck complex actually impinging on and functionally irritating that nerve, and that's the distribution of the headache. It's very often seen as a greater occipital nerve irritation. This is just to describe again the forward head posture. It's quite an interesting statistic that for every 1 inch of the centre of actual line of gravity that the head moves forward with bad posture, the head actually weighs 3 times as much biomechanically. So immediately you're putting all the structures of the neck, the muscles, etc., under massive increased load biomechanically. This is a phenomenon that a guy called Janda in Australia, who I used to work with, described, called the upper cross, which is that basically after long-term changes in their posture, particularly in the upper cervical region, they begin to completely shut down their postural mechanism and simply use phasic muscles. These are fatigable muscles, which is why people who have the fibromyalgia, the chronic fatigue, etc., all come in with these very painful muscles we can all press and find trigger points in, because they are not tonic muscles. They're not designed to have long endurance capacity. They are fatigable muscles that tire very quickly. This is just, again, the neuroanatomy to describe very quickly how the trigeminal ganglion here takes in all of the information for the head, neck and face and positional information, but correlates it with the input from the C1, 2 and 3 levels from the mixed spinal nerves, which is then mediated up through the trigeminal thalamic tract. Interestingly, it also bypasses through the thalamus, which, as we all know, mediates pain. There is another I haven't seen much of this, but it's quite well documented now. You can also get a neck-tongue syndrome, where similarly the hypoglossal nerve becomes involved through its connections with C2 and C3 mixed nerve roots, and they get disordered apprehension. They get slight changes in their speech, articulation, if you like, but they also get a numb tongue, which again can often mimic some very serious, obviously, intra-cerebral problems. I won't bore you with this too much, but these are the pathways by which the neck feeds in intricately with the vestibular nucleus from the inner ear, and also obviously with the other pathways that come in from the feet posturally, but also from the eyes. Most people who will produce this syndrome also become, because of computer work, massively over-dominant on their visual cues. They are beginning to balance by what they see, not by what they feel. And the problem with that is that they immediately, as soon as they get up and do activities, the eyes are confounded because now everything is moving. And remember, one important thing is that the vestibular apparatus in the ear only registers gross deflections in head movement. That's why we do the Hall-Pike test, these great big movements. When they're doing small head movements where the head doesn't turn, the vestibular apparatus almost switch off effectively. So you're relying on your eyes and your postural receptors. If they don't link, then you get dizziness. It's that simple. And unfortunately, we're seeing more and more of it with people spending too much time at computers. Again, this is just shows the mediation between the cervical muscles, etc., and how they feed in with what the eye is telling you and what the spindle fibres, vestibular apparatus, and the joints of the neck feed in. And we're beginning to learn more and more about this with imaging and obviously with greater technology. This is just a list of the amazing reflexes that exist between how you position your eyes, your head, your neck, how we actually stand up, how we follow moving objects. Again, I have a patient at the moment who only has problems when he's actually trying to play football or a ball game, because he has a mismatch between what his eyes are telling him and what his neck's telling him. Treating his neck and giving him techniques which ask him to rely much less on his eyes, balance techniques, core stability, has massively improved and got rid of the problem. But he has seen 21 different people before he found out that this correlation. And this is where I'm saying about the whole subspecialization. The neurologists are far more interested in structural problems relating to obviously his software. The orthopods can't find anything that's sticking into anything, and basically they need somebody who can link the two. And that's really, I think, where we fit in. Lastly, these are just some of the little tests that we do. You can see this lady's doing the stepping test, and she's also got her earmuffs on because we want to remove any form of hearing stimulus and the eyes shut. Believe it or not, we reckon that 40% of people now cannot stand on one foot with their eyes closed and balance on one foot for more than 30 seconds, which is a big worry, particularly the elderly. Looking at osteoporosis, I would argue strongly to say stop worrying about the bone density and stop having them falling over. The reason they fall over is because their necks degenerate and they begin to get the dizziness problems, which then obviously feeds into everything else. But these are just some of the tests we can do. Again, I can happily give anyone a list of these tests. They're very simple to do. You can do them in the clinic. You don't actually have to use the muffs. That's icing on the cake. But it's very easy to do and very easy to read, and will help you make a diagnosis, but also an easy referral to who you think would best treat them. This is quite an interesting little one. Obviously, our feet are ugly things to most people, but they're probably the most important relationship we have with the world, in that they give us all the feed-in information from gravity and our complex involvement with the ground. This is a little test where you simply just push your patient very gently, and as they claw their toes to balance, This is a normal reaction where in fact they claw the toes. The most abnormal reaction is they flatten them and give themselves hammer toes. And that is in fact disordered vestibular information coming through from the feet. And it's a very clear sign that they're not linking their brains really with the rest of their body. This is another nice one that I actually like doing. We actually put a laser pointer on the top of their head. We ask them to put, you don't have to wear the ear muffs, but they target it as closely as they can on the target. They then simply close their eyes, look away, and try and resituate it with their eyes closed. We give them a 3-inch leeway either way, but people with this disorder will be grossly off and be really bothered by how difficult they find it. It's actually an easy one they can replicate at home. You can give it as an exercise, and it's amazing. Within 10 days, they can get it back to normal. What we also see by treating it, rehabilitating it, and getting their vestibular mechanisms back again is that we can actually get the lordosis back. This is a gross example in that she's already had the disc replacement, unfortunately, before we saw her, which is sad because it was probably unnecessary. She had the loss of lordosis, and despite what we've done surgically, you can actually see there's quite a nice, and there is actually a third picture where you can actually see the lordosis has responded very nicely. The multifidus has switched on and is holding her in a much more advantageous position. And interestingly, all her pain from this facet joint, which was really coming from the fact that she was jacked open by the disc replacement and stretching the capsule, has now much improved because effectively the facet joint has closed down again. Dynamic imaging, why it's really important. This is a dynamic MRI, which are very useful. Unfortunately, though, we can only really take flexion extension movements. But it is quite interesting because you can see in flexion, the discs actually do the opposite of what we expect. They actually pop back in relatively as the head is flexed forward, whereas in extension, not only is there not very much extension, but you can see the discs actually pop out again at several levels. So again, imaging is really beginning to not only confound but help us clarify what really goes on in the neck. However, rotation is usually, and side bending are usually problems that most patients actually complain of. Flexion extension are less important to patients very often. This is taken at the ESC scanner. I love this picture because this patient has got everything. He's actually hypermobile, which is a big problem to him. He has all the vestibular stuff going on. I call it vestibular, let's call it dizziness, giddiness. But more importantly, his MRI actually was recorded as normal. As you can see from this is the anterior aspect of the cervical spine. You can see here is his C1, there is his dens inside. He has a grossly dysmorphic C1-2 complex. I don't know if you can see that, but there is a normal facet joint on the right there. And the left one is actually twisted right off to the left, and his C1 is actually sitting rotated to the left in a normal position. If we activate the... No, sorry, hold on. This is rotation right, okay, and we keep doing it. You can see, and in the next one, which I'll show you again, let's just keep doing it for a second. You can see how, unfortunately, done it again, sorry. Technology. This is now looking from above, as Simon said, we can orientate. That is the same scan, and we've simply flipped upside down, and now we're now looking down him actually, so you can see deep inside his neural canal here. These are the various levels below. Here is the C1 ring. There is the head of the dens, and these are the shoulders, if you like, of the axis sitting on the atlas. Sorry, other way around. But basically, this ring, as you can see, is rotated quite dramatically as normal anatomy. So unsurprisingly, he had a much reduced range of movement in one direction and gross over hypermobility of this facet joint here, which is also slightly beveled. His pain is all underneath that side. He doesn't like rotating, he doesn't like extending, and in fact he's just undergone a denervation for this because nothing's going to fix this in physical therapy. It's a disordered pattern of movement, but a denervation in fact has cured his pain. Denervation is a process by which we knock out the small rhizome that supplies the joint, and very often it has great success, as it did in this case. If we hadn't had this imaging, we would have never found this, because the slices that we have, possibly an oral x-ray, but again it's a three-dimensional image with a two-dimensional facement, so this massively opens up the possibilities of what we can pick up. This is the posterior aspect. This shows it rather nicely. Here are the spinous processes, and you can see this very, very misshapen facet joint on the left here, and you can even see the neck of the dens is rather distorted. The shoulders, if you like, of the C2 are very distorted. And again, this shows... Sorry. You can see it there. The left one is dipping right down past, and on rotation the other side is minimal. He's happy to go left, very unhappy to go right. So we've just come in and we've just zapped the capsular nerve that supplies this joint, and basically we've got rid of most of his pain. This is an image that actually Simon showed earlier, but it was a patient of mine who'd had long recalcitrant pain in his low back. He has actually had, which you can't see, a disc replacement. It's sitting at the front here. And why this was so useful is we couldn't MRI this section because we couldn't shut down the artefact that was blocking. What he has in fact happened, probably I'm afraid as a result of being jacked open again by the disc replacement, he's had a pars fracture at the back. But this was almost impossible to image before now. And again, you can see on this one here that the pars defect is difficult to see. It's a little bit easier there. But until it moves, which I'm hoping it will. No, they're not going to do it. It's not. Okay, here we go. This is the nice image now. This is the full picture. There is the disc replacement. You can see it's a very wide interspace there. He actually had a very degenerative L5S1 disc where the surgical intervention has obviously gaped that open, distracted the facet joint, and due to the change in dynamics, he's had a fracture at the back. And if we just show, you can see it actually moving. Just there. It's quite a big deflection. So what are the results of all this? Well, I'm proud to say that because, next are just my specialty really, but in a predominantly neurosurgical unit, we've actually managed to reduce the amount of neck surgery that had been referred to us by up to 85%, which is quite a big result. Most necks and lumbar spines are usually operated on far too early, and this is what we're trying to prove. If you can restore the function, very often the structural anatomy really doesn't matter. And it's amazing what the body will put up with in distorted anatomy. It will adapt. And so function is everything. Sorry. So just the take-home message really is a bit more a joke really. Dynamic people thinking in dynamic ways about dynamic imaging and dynamic treatment. And hopefully we get dynamic answers. Thanks very much.
Thank you very much, Nick. As you can see, it's a real challenge when you've got something as simple as neck pain, working out all that physiology, that anatomy, and how we fit in our imaging tool to provide the best answer. And we're always striving for the next best thing. And it has been quite enlightening for me to see how we can actually help that. But, as I say, as you can probably understand, I learn as much from working with people like Nick as I do surgeons. So it's a tough job for all of us to work together, but it's critical to getting these things right. Now, we're going to finish now with a good friend of mine, Brian English, who's going to come and talk to us with his laptop. And I'll move to one side. You had a bit of a tortuous journey, haven't you, Brian?
Started yesterday.
Yeah. I mean, he's made a real effort to get here, and I'm very grateful that he has come along to tell us about his experiences of managing football injuries at Chelsea Football Club. It says here, Brian, separating fact from fiction.
That was your title, son.
That was my title, okay. Yeah. Do you have another one?
No, that'll do.
That'll do. Okay, good. Thanks, Brian.
No, I while we're setting up, I'm sure you are not particularly bothered about hearing about my journey over the last day or so, but it's going to fill the gap whilst we're setting up here, so I'm going to tell you anyway. Yesterday, leaving Heathrow for the 9 o'clock to go to Munich. There was a bit of fog, so I ended up getting to Munich at 6 o'clock, so I couldn't get the plane back, which was delayed furthermore to get me back today. But I mentioned Munich just because working in sport, learning from colleagues in different countries is something that we're used to doing in the medical profession, admittedly. But learning from German people with regards to the way that they practice their medicine, specifically musculoskeletal medicine, certainly taught me a lot, and also made me look a little bit more as well into the German literature, because if I may comment about the people in my particular specialty, that the English-speaking literature is one that we're sort of very familiar with, looking at the research that comes out of Australia and possibly Scandinavia and America. But the German literature is something that we don't look a great deal at, and they have done a lot of pretty dynamic work in musculoskeletal over the last really going up to 50 years. So, my form of work, I need to have a close relationship with radiologists. In fact, probably closer relationship with radiologists than with any other profession or any other specialty aligned to sports medicine. Days off work, I mean, sometimes when I talk about this, I mean, this doesn't look particularly important, does it really, when people are in specialties such as our previous speaker, when you're talking about relieving somebody's neck pain, replacing discs in the neck. You know, at an undergraduate level, well, how important really is a hamstring tear or a gastroc tear? Well, of course, to us, it is extremely important, and the difference between back in 17 and 21 days is very important to us, because it may mean another game, and it may mean a victory, it may mean a lot of money, and in some cases may mean you're keeping your job or not. Just out of interest, what do you think is the most common of those injuries, the most common cause for days off work in professional football? I'll answer that at the end. Fascial injuries in football. Again, I'd worked in several sports before I worked in football, and a muscle injury is a muscle injury, is it not? Well, to us, again, it is not, and specific reasons for that. Because a fascial injury in a sport such as football, and if the radiologists are telling me that this is a fascial injury, makes me quite happy, because it goes with the kind of history that is specific to either getting a fascial injury in the muscle or a true contractile tissue injury. So a subtle history can point in towards that particular direction, and the most important thing for me there is return to sport. With a muscle injury, you're back in about 17 days, and a fascial injury, you're back in 11 days. So you can encourage the people that you are working with that you can go a bit quicker if it's a fascial injury. You can get to a higher functional level within 48 hours, maybe, rather than 96, as it were, 2 days rather than 4 days. Get them to a higher functional level, and therefore you get them back quicker. The pressure on us is to get people back as soon as we can, and we would view it as a failure if they get a recurrence of that injury within 6 weeks of them sending back, or of course during the rehabilitation process. If we get them back nice and quickly, and we have Champions League audit to compare what we're like compared to other teams, and they don't get a recurrence, then we can give ourselves a pat on the back. You don't often get a pat on the back from other people in football, because if you have one person in the treatment room, that is viewed as one too many. There is still a bit of an adage out there that it can be the medical team that cause the injuries, whereas, of course, you know as I know, it's the coaches that cause the injuries. Ooh, controversial. So, again, these little feathery appearances of the fascial injuries, great for us to see. I mean, I think we could do some of these, Simon, after a game, and we would probably see injuries such as this anyway. So we don't treat the scan. Of course, we do treat the player, but nice injuries to see. So that would be my summary of that. You might think I'm going a little bit quickly, but I realise some people in the audience will be thinking in 4 minutes' time England do kick off against France, and you may be a bit concerned about that. Therefore, for you, I'm just going a little bit faster than I normally would do. I just want to show this is a little bit away from radiology, but this was probably one of the more profound moments that I had working for this particular football club, and one where they should observe the rules of the game and apply them accordingly. This player that drops his knee into the side of that goalkeeper's head, by the way, fractures his skull. He ends up with 2 spikes of bone going into his brain, and he's out for many months. But you look at that on video, and that has to be worse than an Eric Cantona doing a kick at someone in the crowd. That needs to result in some kind of punishment rather than nothing. When you could have obviously permanently brain damaged that particular player by doing that form of tackle. It's interesting for me, and maybe all the radiologists know that here, that this particular player was susceptible to this type of injury because he was one of triplets, and that part of the skull is thinner in triplets and twins than it is in those who are not a twin or triplet. That was something that I did not know. But he continues to wear a headgear. As I see that a player in Inter Milan, after suffering a skull fracture, also wears headgear now, and that's an outfield player. Young people in the United States are encouraged to wear headgear, and maybe it's something that we'll see more and more in the sport, and therefore we'd have to see less of this, where we have to end up imaging these people after the injury on neurosurgical units and treating them accordingly. What do we do about those people to get them back on the field of play? Well, I mean, imaging doesn't take us a great deal further, but we do have to assess these people from a neuropsychological point of view before they go. Interestingly, when we started doing that, by the way, we found out that all our footballers were above the average IQ for the general population. A couple of wry smiles in the audience potentially there. Now, I would wager that that is different compared to players that maybe play for other teams. And my theory being that to play at an elite level and to understand the intricacies of the tactics and to read the game in the way that some of these players do, I think you need to have a certain amount of intelligence. To put the ball on somebody's foot and predict where you want them to run to, not where they want to go themselves, it is for the truly elite people, they need to have a good and a quick brain. I throw this one in. This is in exactly the same game, so that was number 2 goalkeeper rendered unconscious. But again, foul play. Sonko comes up here, he's ducked his head down, he's using it like a battering ram, so again it's a weapon. No punishment during the game, no punishment afterwards. Only that keeper number 2 there kindly is lying on his back. Great, so when I go up to him you can manage him straight away. It's nice and convenient for him. But he was unconscious, but he left hospital that evening and was able to play once his neuropsych scores got back up to normal, as well as all the other aspects of treating a head injury. He was back in 2 weeks, whereas the other goalkeeper was conscious when I arrived, a little bit confused, a bit dazed and confused, but was talking to me, looking at me in the eyes, yet he was obviously substantially worse. So initial impressions when you get onto the pitch, if you haven't actually seen the mechanics of the injury, because you're down in a dugout, can be a little misleading. I hope this video works. Let's just see if it does, because it's not going to work. Never mind. Right, this is the last one of the head injuries. This was a cup final in Cardiff, and there's the impact. But again, the player's gone onto his back, which again makes recovery from the field of play quite... it's easier to start with because they're in a position where you can manage them. You may see, as in you did with Cudicini, that their arms start moving like this primitive reflex indicating to you as you're running onto the pitch that he's had a bit of a stretch to his brain stem. And when a player is like this, now, this is what I wanted to say, you see what's happened to his neck and you see the way he's been managed by the players, and a member of the medical staff from the opposition comes on and doesn't do a much better job. Now, the only reason why I wanted to say that is that part of the management on the field of play is educating the players about what they should and should not do, and obviously in that situation is leave them alone, we're only a few seconds away. But also educating people that you work with. So we are all at the same level. And following that incident, England now, you have to do a 2-day course, and you have to pass it. Otherwise, you're not allowed to work in the Premier League on rescuing people from the field of play. So there's a certain standard of ability removing people from the field of play. The rest of Europe hasn't caught on with this yet, but at least now we have some standards. So your player is going to be looked after if the opposition person is there early, which is very unusual. He just happened to be behind the goal at the same time. But especially when there's a lot of people watching and there's video evidence there, it's good to know what you're doing when you're managing these kind of problems. You know what? I'm really going to skip through this bit extremely quickly, but just in case you wonder what it is that we do in football, because I have that question asked to me many times, is that prevention is very important for us to prevent the injuries occurring in the first place, because the pressure is on you when injuries occur, because they will always come to you asking you, why is this player injured? And depending on your relationship with the manager, depends how much you can discuss it with the manager. Well, maybe after that particular game, you doing a 90-minute very hard training session was maybe not wise, and they should have done a recovery session. So it depends what your relationship with the manager is like. But with more technology that has come in to assess the players, then you are able to give the feedback, look, this player is going into fatigue, he's not performing as well in games, because you can monitor them in training and games, see what their heart rate response is to a measured activity as well. So the one point of interest that comes out for us, and I'll just mention this one, I won't go into too much detail on this, but we have noted that the training intensity, in other words, the harder the training is with regards to the intensity, not the duration and how far they run for, but the intensity of the work, then injuries go down. Whereas if the training intensity is low and they're doing more plodding type of work, then the injuries go up. So you might think, well, the harder they work, surely that's going to be more injuries, but it's the other way around. When we had a chap called Scolari, his Portuguese manager, his particular coach, fitness coach, did very straight line running work, which is quite popular many years ago, and our injury rates soared in about September, particularly muscles, like it never happened before. Whereas this coach, as well as one we had called Marino, high intensity work, very much that the injuries are reduced. So I'm a firm believer that it is the coaches that cause the injuries, but you have to be careful who you say that to. Last thing on this is that with these accelerometers, you can measure the difference on what happens when the left foot hits the floor compared to the right. So again, for us, and the end stage of rehabilitation, we had a player recently, this player who had a chondral defect on the lateral femoral condyle, and you could see that he was decelerating without the same speed. Let me rephrase it. His ability to decelerate on the affected leg was poor compared to the unaffected leg. So, not ready to go back. Maybe susceptible to an ACL injury, for example, because landing on that leg, he guards it. He decelerates with his right leg, he doesn't decelerate as well with his left. So, end stage of rehabilitation, you're wanting the 47s and 53 comparisons to become more 48 and 50s, so they are the same one side compared to the other. All about injury prevention. This was just to finish with a few little cases that it's always interesting for me how much imaging helps us and how much sometimes it can harm us. This was one of our forwards who developed a little bit of a tweak at the front of his thigh. We're always worried about rectus femoris injuries because they're a bit of a nightmare for us. We find the muscle hides, doesn't give us information, and then it can tear and recur. So we sent him on for MRI, shows him a bit of edema there within the muscle without going into more technical detail. So you could look at that and think, oh, well, he's got a grade 1, grade 2 injury. Just going about the grading of muscle injuries because, again, grade 1 and 2, 3 for us means nothing. Grade 1 being, a millimetre or 0, grade 3 being a total rupture, so grade 2 is the other 99%. For me, it's meaningless. Whereas if we're given a 3D representation of the size with regards to the 3 planes and what percentage of that muscle is damaged, that is maybe a little bit more helpful. May not change what we do. However, the European audit looking into this 3-dimensional analysis now of the tear of the muscle and how quickly those tend to respond as they have approximately 1,500 hamstring injuries and increasing will maybe get us to the point where the size of the muscle is not size of the injury is not a predictive factor, whereas it could be. So anyway, They think he might be out for 3, maybe out for 4 weeks. Within 24 hours of me telling him what the diagnosis was, his pain had eased and he wanted to train the following day. He was adamant he was going to train. So I warned him about the problems with that. Anyway, he played within 48 hours. So there was one where the MRI would suggest we had a little bit of a problem here, yet symptomatically completely normal within 24, 48 hours and played. We've had tears in vastus medialis, 3 centimetre tears in other muscles, a little bit of a discomfort, but completely symptom-free within 1 to 2 days, and end up playing in 3 to 4. So it very much the radiologist working with us, but it's the clinical that takes it a little bit further. That was did about rehabilitation of the sand, which I'm sure we need to discuss at this stage. The transverse process fractures in football, I mean, that's so useful when the radiologist that I work with can help me, because if the player comes off the table and he is told that he's broken his spine, I've got a lot of work to do to undo that. Whereas if it's a transverse process, and the literature states if you break 3, it's approximately 3 weeks to get back. If you break 2, approximately 2, and 1, approximately 1. It's nice when they fit into that little box. So this was a fractured transverse process. More often than not, it's a damage to the soft tissues to actually get through there. This was an elbow. The player finished the game, but stiffened up a lot afterwards. But with a damage like that, the radiologist could be great, because he can say, "Oh, I've seen a few of these, no problem. They've had them back sometimes in a week, etc." You're already started that rehabilitation process, rather than you've broken your spine. This is going to be 6 weeks for the bone to fix. That bone doesn't need to fix before they get back and playing. And something like that, we would have them in the water doing some aquatic therapy the day after. In fact, for most of our injuries, we would say get in the water the following day, unless there's a specific reason not to. And the same goes for post-surgery. I put that up just because these CT images that you people are sending me these days are absolutely wonderful. They're probably all old hat to you, but they're like toys to us. And I saw your imaging of the cervical spine. I mean, I think it's absolutely incredible where you can take us and our profession for that. An ankle syndesmosis problem, I put that up. It's just, again, these are particular nightmares for us, and it's a little wee ligament in there, but so much not bothered to an extent on the lateral ligaments. But perhaps, can you just give us 100% confirmation what is going on that anterior and posterior inferior tib fib, because it's so crucial. We can either get them going really quickly, or we've got a problem. We've maybe got an unstable joint. These give us a big problem with a little bit of a bleeding over the iliac crest, but a hip pointer, which it is. A bit of a blood, not too much of a problem, but that's the kind of thing that would keep a player out from our point of view for 3-4 weeks, because of the effect that it has on the abdominal musculature. So again, when I'm giving these stories back to the radiologists that I work with, giving them the feedback, this is how long he took. The next time the radiologist sees it, he might decide to take it a bit further, may decide to scan, or was it a passing comment because the player's a bit bushy. He can say, that's not just a bruise, this is over the top of that crest. You could have a little bit of a problem with that. This was an open kinetic chain injury, so in other words, this player's foot was in the air and he had a kick on the outside of his foot which knocked off his medial malleolus. Don't know if anyone's come across that before. But pre-imaging showed that there were no stress signs in there, but somebody like myself would come back to you saying, could you have a closer look at this imaging? Because we can't believe how somebody can have their foot kicked on the outside of their knock-off a medial malleolus without there being pre-existing stress injury, because from a medical legal point of view it's important, but post-injury, if there's any way that you can start to determine for us, yes, this was the case, whereas on this particular case it said there was not a pre-existing stress fracture due to an image that was done 2 weeks before, but I wonder whether you'd be able to give the answers for us for that. And the last one was a player of ours who got a kick in the chest, and actually he got booked for being kicked in the chest. Yes, we were playing Manchester United that day. And he had to go to his homeland very soon afterwards, so we just thought we'll miss the X-ray, could be a bit of a fracture, we'll just go straight for the CT. And just on this particular occasion, these wonderful 3D CD images did not show us a fracture, and the X-ray that was done in Africa did. So technology didn't get us too much further with that one. That, Simon, is all I'm going to leave it. Thank you.
Thank you very much, Brian, for...
So this was just coming through. So the actual answer was this was in increasing incidence of the hamstring tear was there, and it's the medial collateral ligament.
All right.
Most common cause. Okay.
Thanks, Brian. Yeah. Well, thank you for completing our journey, and thank you for completing yours.
Thanks.
But no, I mean, I think that I wasn't aware, in fact, not being a fan of the round ball, my balls are other shapes, that England were playing France. So in deference to that, I'm very keen that we have an opportunity for questions if anybody has them, but maybe just 2 or 3. If there's any burning questions from the audience. Yes, Mark.
How much radiation does that kind of 3D imaging give to patients?
This is going to be an area of a lot of scrutiny, and it'll be also an area where there'll be a lot of argument between manufacturers, because actually you can imagine it's going to be very complicated to work out. In terms of its benefit, I think that if it's used in a targeted fashion like I spoke to, we don't really need to take, in particular for the extremity work, obviously, too much concern out of the amount of radiation from this type of scanning. It's the whole body scanning and the sort of the poly scanning for multiply injured patients that is a real concern. Paul, do you have anything more you want to add to that?
Just it's low.
Yeah. You know,
you're talking in sort of orders of X-ray equivalents rather than hundreds of thousands of X-ray equivalents.
We're talking about, in case you didn't hear that, you know, this particular machine will give about a chest X-ray's worth of dose for one of their investigations, and say if you're looking at the heart. So I think that as long as it's targeted, you know, there's an awful lot in the press at the moment about increasing use of radiation, and the CT manufacturers will pick up on this, and they'll all start making arguments about who's the best and who's got the lowest dose. My point is, in this particular type of focused targeted scanning, the clinical benefits are in a bigger scale of importance compared to concerns about radiation dosage. Does that sort of address your concern? Thank you. Yes, sir.
The coloring of the density of the different pictures, is that in any way called pathology or not, or just that an artifact of the machine itself?
The three-dimensional movies. Yeah, this is all to do with the workstation. When you put the data into the workstation, you have to set the window levels to sort of strip, if you like, the overlying soft tissue away. And it's really difficult to get it quite right. You never end up with a nice clean bone surface like you'd hope you would get, because you've got sort of soft tissue stuck right next to it. And it really is quite a challenge to get it looking. Yeah, my pelvis looked really moth-eaten, didn't it? I didn't think that was abnormal. But you know, that's just the way in which we'd set the window level. You can play with it for ages to get it right, but there's so much data there, and you're sort of trying to do so many things. So that is an artifact. It's not actually relative. It's not related to pathology or bone density or anything like that. We'll get better at it, I guess, is the answer. You know, these are our earliest attempts. You know, we really need to sort of refine and understand how to make that machine sing and dance and use the workstation properly. Are there any other burning questions? Well, as I see none, I think I'd just like to ask you to once again thank all the speakers for some making Herculean efforts to get here, and to yourself. Thank you very much.